ELSA TV episode 7.
Yes.
7. Okay. So, thank you, Professor Mahir Osman, for joining us for ELSA TV. And this is an honor for me and Ong to host Professor Mahir for episode 7. So, before I start, I think I will introduce my co-panel, which is Dr. Ong from Singapore, bariatric and digestive surgeon over there. And he will be helping me to, and he'll also be conducting this panel discussion. Ong, you want to say anything?
No. Thanks, Kafu. Yeah, thanks, Professor Mahir, to agree for this 7 episode. Even though you are very busy, yeah. So I know you are just finished the operation. Yeah,
Yeah,
so hope
just finished
everything is
it.
going well. Yeah, and then just to update all of you that Professor Mahir Osman is the current president of the ELSA. Yeah, so we are honored to have Professor Mahir to discuss about the bariatric and metabolic surgery, which Kafu is an expert in the bariatric and metabolic surgery in Malaysia. Yeah, so we are now 3 bariatric surgeons meeting here today and to discuss about the future of the bariatric and metabolic surgery, especially with the anti-metabolic or obesity medications era. Yeah. Maybe
Great.
Kafu, you can start. Yeah, thanks.
Yeah. Okay, Prof. Maybe you can start to tell us how you got your roots in bariatric surgery first. How did
Yes, thank you.
you start
Yeah.
this?
Thank you, Gafur, and thank you. Oh, it's an honor for me to be with you again. Yes, Gafur. I mean, I I I do surgical oncology and bariatric surgery. So I started in 2000 doing bariatric surgery. First sleeve was in actually in 2002. By 2004, I think by Michel Gagne. I used to. I have been there and I have seen the uh, how he is doing this sleeve gastrectomy, and then I started doing sleeve gastrectomy in my country, and then it's followed by MGVs, randomized. I mean, duodenal switch, robotic bariatric surgery, and revisional surgeries nowadays more common. But I have to say that during my 25 years of bariatric surgical experience, I agree with all that the surgery, uh, as number of surgery is not decreasing, but every year most patient is actually preferring to have medical treatments instead of surgery. Now we are dealing with really difficult cases with the BMI over 50, and also cases for revisional surgery who had either complication or who had weight loss failure and needs complicated complex surgeries to actually improve their situation. So for the future, I believe surgery is going to be there anyway. I mean, you cannot say that because in my country, every year 100,000 patient gets bariatric surgery. So 42,000 of them comes from outside. So mainly from European countries. They come mainly from England. So in England, they do something like 2,000, 3,000 cases in a year. But we operate on something like 15 to 16,000 British people for obesity surgery in Turkey. So, I mean, if you look at the numbers, I believe the surgery is going to be there. But as I said, we're not going to deal with the 35 to 40 cases. We will be dealing with mostly over 45, 50, or patient with the diabetes.
Do you see that the trend of the patients that came to you 10 years ago and now, that means what you're saying is you don't get straightforward, BMI, more than 40, those kind of cases don't come anymore. Now, predominantly, those are revisions and those are the ones that you're getting now are mainly complicated cases as opposed to just the regular person coming to you and saying, oh, I've got diabetes and my BMI is 40. Is that what's happening? You think the trend?
the group of patient we lost currently is patient between 35 to 40 and with the comorbid disease. So because of the medications, they don't come for surgery. They try medications. And only some percentage of that patients comes for surgery. But if the patient is over 40 and especially over 50, even if they use some medication, at the end of the day, they come for surgery anyway. And most patients who are using liraglutide or semaglutide, liraglutide, I mean, the Saxenda is more common failure. When they stop medication, they will put some weight, so they will come for surgery. But for semaglutide, Ozempic, and the similar medications, they try now, and they believe that it's effective. And we think we will lose that 35 to 40 patient, and we will get over 40, especially over 50 with some kind of comorbid disease. As I said, I mean, I believe that paradigm at the end of the day is going to go for some kind of medication. So surgery is not the end for bariatric surgery. I mean, the obesity problem. So obesity is not a surgical disease. So if you can actually treat with proper medication, surgery should be kept eligible only for super obese or patient with complications or patient with who needs revision for the previous surgeries. What do you think? Oh, I mean, in your country, in Singapore, and in all the ASEAN countries, the BMI is actually much lower for the indication of surgery. What's happening in your side? What's happening in Malaysia, Gafur? Also, I would like to know for that as well.
Malaysia, the problem is you cannot get the medication. It's too
Ah,
difficult. So it's it's very, very difficult to get stock. So
surgery is
that
still on. Yeah.
yeah, so that is the thing that is still driving the surgical part of it. But I think more and more patients are coming, and they basically want a combination. They don't want just surgery, or they don't want
Most
just
medical.
medicine. They want a combination. So I think this is the new trend that personally I am seeing in Malaysia. I'm not sure on whether in Singapore, what do you have there?
Yeah, so in Singapore, it's quite interesting because we have the medication available. Yeah, so some of the group of the patients not keen for surgery. So for them, medication helps. So they
And
manage to eat and
also,
some lost weight. Yeah.
there is a
But
group of patients, I mean, with the BMI over 50, you might give them some medication
yes,
Yeah,
to make them to lose 10% of the
yes.
excess weight and then go for the surgery. So
Yeah.
that's also useful for us. But I used to do, there was a trend that I used to do something like 700 cases or 1,000 cases in a year. So it is what, something like 200 cases, 150 cases in a year. So that's related to increased number of the surgeons in Turkey, but also the most patients are actually trying to have the medication first and then ask for the surgical treatment. And the cost of surgery is getting expensive now. I mean, Gafur and Arun keep sends me the cheap places in Istanbul, but I mean, there are only a couple of
yeah,
places. I mean, this altruism. There are only a couple of places like that, and in most places it's over 5,000 US dollars. So it's not cheap, and that's why people try to have medication first and then go for surgery. So I mean, the obesity surgery and obesity treatment is not for the aesthetic reasons. It's
yeah,
for the treatment of the disease. So if
yeah,
the patient has a real obesity, and the drug is not going to work anyway, they will come for surgery. So
yeah,
if you accept this, then yeah, we will do the proper cases. In Turkey, and more commonly, everybody tries to do sleeve only,
yeah,
uh, or sleeve plus procedures, and the
yeah.
number of gastric bypass, especially MGBs, and number of SADI and duodenal switch is keep decreasing. because of the possibility of having medication if there is any failure after surgery. So you can start medication and make patient to
Yeah.
lose some weight. Yeah.
And also, I think some of the current trend in the newer surgeons, they don't want to learn very complex procedures anymore. They don't want to. They find that they want to learn the simple procedures, and they want to do it well, and they somehow or other are very happy just doing that. So I think that is another reason.
Yeah.
Um, I actually want to
Orası
ask you,
dalak.
Mahir. I want to
Orası
ask
dalak ama. Orası
let
dalak
Mahir
tarafı.
finish off first.
Yeah.
Yeah, I want to ask you, Mahir, if you can now go if in this era of bariatric surgery, if you are just say you're still very young, but if you are a younger 30-year-old surgeon now and you are embarking on bariatric surgery, what type of strategy will you take to make sure that your longevity in this career will be there for the next 10, 15 more years?
Good question. Very good question. Because I'm not only bariatric surgeon, I do surgical oncology. So I do rectal cancer, stomach cancer, pancreatic cancer, plus bariatric surgery. So, I mean, we are different term of different surgeons. So if you go back 20 years from now, and you will see the most surgeons like me, then they intend to do everything. So, but I believe subspecialty. If I'm going to choose some kind of subspecialty for the future, yes, bariatric surgery is going to be there, but it's going to be more complicated. Uh, I would ask. I mean, same thing for the cancer. There are many vaccines and many immunotherapies and everything. Place for surgery is decreasing as well. But again, I will ask them to go for surgical oncology mostly instead of bariatric surgery.
I agree with you
So
on this. I
yeah,
agree
yeah.
with you completely. I think,
And also
yeah,
the youngest people needs to learn new technology, including not only laparoscopy, robotic surgeries, the new 3D printing, virtual reality, and try to use all that game stuff to stay in the game. Otherwise, you will be out in the future.
yeah. I totally agree. I think 10 years ago, even 5 years ago, you can be a bariatric surgeon and you can remain very relevant. But now you might have some difficulty.
Yeah, true.
The science of it is just so much. So I think the cake is just too little. Okay, I'm glad, Mahir, you mentioned about robotic. So, Mahir, what type of practices you think will be very suitable for in terms of bariatric surgery? What types of robotic procedures will be suitable for it?
Well, I mean, I start with sleeve. So everybody starts with sleeve because easy to
Yeah.
learn robot. If you are
So
starting
so a
to robot
sleeve,
as a
uh,
bariatric surgeon, but
so
sleeve is not,
yeah, a lap sleeve
sleeve
and a
is
robot sleeve will be different. You think?
no, exactly the same. Exactly the
Right.
same.
Right.
Robotic is easier, but it's very expensive. So, but it's easy to learn how to use robot. So if you are not a experienced robotic surgeon, but if you are an experienced bariatric surgeon and planning to start a robot, better to start with easy cases. Sleeve gastrectomy, cholecystectomy, something. The first a couple of cases. So if you do two sleeves, and then you will see the difference between laparoscopy and robotic surgery, and then you can do more complicated cases. What I do is currently I don't do robotic sleeve because it's expensive. Laparoscopy is much easier, much cheaper. But I do, and the staple of the robot is 8 times more
Expensive.
expensive than the
Yeah.
laparoscopic one. But what I
Mhm.
do is I do revisional surgeries by using robot,
Yes.
and also
Right.
I do complex cases like single anastomosis, duodenal switch,
Yeah.
SASI, and
Yeah.
transit bipartition, and
Mhm.
mini gastric bypass. Even if you do robotically, it's much safer for you
Yes.
and for patient.
Yep.
Otherwise, I mean, if you are doing private practice, everything is related to money. I mean,
Yeah.
if your patient doesn't want to spend more money, so you have to go through and do laparoscopy. But I cannot
Mm.
say same for the cancer, especially for the rectal cancer. So
Yeah.
if you have a robot and if you have a rectal cancer, better to have it done robotically because it's easy to dissect inside the pelvis, and also you can actually see 20 times magnification, and also you can control the anatomy much better than laparoscopy. So my case is still going on, and I need to open up ileostomy for the patient. As
Yeah,
the
please. Yeah, yeah.
yeah, if you
Yeah.
can carry on for a while, I'll be back in a minute.
Yes, yes. I think you can carry on, Mahir, and then we will get back to you if we are still here. Okay.
Okay,
Okay.
okay,
Thanks.
thank you, bye bye.
So, Ong, what do you think, Ong? Mahir is in the stance that there is some benefit in robotic sleeve. I personally feel that it's a longer operation. It is more expensive. It's more tiring, actually. Personally, I feel more tired sitting down there for 2 hours doing a sleeve robotically than doing one in 45 minutes, 50 minutes. And the outcome, to tell you the truth, patients have got more pain with the robot than they have with laparoscope. So I don't know.
Yeah, so I agree with you, Kafu. So robot or the more advanced technology, there's some things to sort of uh, tailor accordingly to the complexity of the surgery, right? So complexity of surgery, of course, robot, wristed instrument, all these things might help. And then the future is also the digital surgery, right? So for digital surgery and then the navigations, AI, right? And computer vision, all these things. This might probably digital surgery wise, robot might help, right? So for those robots to have that kind of the capability, right? So then we need the data to feed, right? So the way the mechanism, how it drives. So they may have a different type of the procedures. So to do that, I think the first off is the cost need to be come down, all right? The cost need to be down. And second is that if you do reduce port with
Do you think
the
do you think a
5 mm port,
hybrid
right?
but do you
Yeah,
think a
correct.
hybrid one, that means you use the robot to dissect, but you use the normal laparoscope stapler to fire? Do you think this is something acceptable?
I think that is something that I think the United States has come out, right? Because you use
Yeah.
there's a paper coming out, the robotic stapler firing versus the laparoscopic staplers.
Yeah. That means they do
Laparoscopic
all
stapler
the
is cheaper.
operation robotically, but the stapler is being fired
Yeah.
on the patient. So I don't know lah. I feel that it's like it's you're just using the robot sometimes just to use. I mean, personally, that is what I do lah, because I'm in private practice, so I have to cut down cost. So I dissect everything, whether it's MGB or RYGB, but the stapler is fired using a Medtronic or a J&J stapler, because it's 8 times costlier to
Yes.
use the but when I look at it, actually it doesn't make sense, because you are doing the most important part of the work is being done by the normal stapler, not being done by the robot, you see. So I
Yeah,
really feel
so
that
the other options you can save cost is that whether you would like to do the hands-on, like last time, old time, right? We do the open.
hands on, yeah.
Yeah, right. So you can do the hands-on because robotic is easier to do the hands-on, right?
Mm,
So this is before the stapler eras, right? They have used hands-on. I mean, last time when I was a trainee, the open like GJ is done by the hands-on. So
mm,
with the
mm,
obesity patients, with the robot help, right? Maybe
mm.
laparoscopic suture will be tiring, right? Because of the no fulcrum effect and then the
Yeah,
the
yeah. I,
wall.
I, I,
So
I
with
think
the
so.
robot, so it may probably you rather than using the stapler, you can cut the cost by doing the complete robot hands-on
Yeah.
for the anastomosis. That might potentially save cost and then also the potential use of the robot.
Yeah,
That
I,
might,
I, I,
that might be
I
something.
completely agree. I think there has to be a balance on saving some cost as well. Um, okay. Now I'm sure you have trainees with you, and
Mm,
in Malaysia, the most popular procedure is still the sleeve gastrectomy. I would say 90% of bariatric procedures in Malaysia is still sleeve gastrectomy. The reason is because there is also is easy to be done, and also I think the financial element also attracts many young surgeons, a quick procedure, patient in, out, overnight stay, post surgery, day one, day two, and there is results. But what about the newer Sleeve Plus? Are they gaining popularity in Singapore?
Okay, so in Singapore, currently is the sleep plus procedures are not in the code,
Mm.
the
Or not
treatment
in
code,
the
not in the
okay.
code. Correct. So you only have currently we only have a sleeve bypass, right? So sort of traditional one. So I think currently in Singapore is most of the time either we do sleeve bypass or sometimes it's a one anastomosis bypass, right?
Okay.
So these are the currently the condition in the Singapore, right? So
Okay.
whether
Okay.
sleeve
Okay.
or bypass is the bypass is less and less popular as we all know, right? And
Okay.
then the bypass is a more sort of complex as well as the nutritional all these things, right? But I think
Yeah.
still the good procedure, I would say, right? So in
Yeah.
my case mix is we choose accordingly to the patient needs, right? So for the reflux, right, and then a lot of reflux that you probably will not offer sleeve, right, because it might cost more
Yeah.
reflux after the surgery. So then the
Yeah.
bypass might be maybe better. And then for those with the long-term diabetes, I know, then the slightly higher BMI, then and a smoker, right, then we cannot do the bypass, right?
Leave lah.
It's not good for us. So in that case, we need to switch to the sleeve, and
Yeah.
then as a stage procedure or not if you need it, then we try to repair the hiatus also lah. So currently with how I would like to suggest is that based on the patient needs and the patient's the profile, right? We need to advise accordingly. So that's why nowadays, like earlier we discussed about the oncology, right? Surgical. I mean, you both of us are also the oncology, right? I mean,
Yeah.
upper GI oncologies, I still interested in it, right? So most of the
Definitely.
treatments are oncology. So it's a MDD, right? So to me, the oncology has been established as a multidisciplinary, right? The treatment, right? So bariatric or obesity surgery is also the MDD, right? MDD approach. We have a psychologist, we have a dietitians, we have a exercise physiotherapist, right? And we also have the endocrinologists or physicians to help us, right? So this is a really a MDD approach. And then now with the Lancet Commission has stated that there's a disease, right? Chronic disease kind of situation. So I think similar to the oncology, right? We are moving toward that direction for the obesity and metabolic surgery as well. Yeah.
Yeah. Hey, Ong, what do you think about all these Chinese staplers now? What is your opinion on it? Do you think that I use Panther personally, and I'm quite happy with it most of the times. But do you think that they are catching up soon, and do you think that they will kind of come to a stage where, like how BYD is dominating the EV market, the Chinese staplers will come into the market soon?
I think it eventually is the cost and then the efficiency, right? And then the
Mm.
safety, right? So as far as the stapler is safe for the patient, right? Let's say less bleeding rates, less leak rate. I think to
Mm.
be honest, is most of the staplers, the stapler related failure, right? I call it mechanical failure, is nowadays is quite minimal, right?
Yeah,
Because
very
most are
low.
CE mark and then also by the safety profile has been quite
Yeah.
being sort of reliable in the sense, right? So in the future, I think you are right in the sense that the market share will be taken over by for those with the affordability is the one, and then second is the safety, right? As far as the safety and then affordability is there, I think that product will become a market lead. You know what I mean?
I'm quite happy, I have now they have we know that the ultrasonic Chinese ultrasonic dissector has been in the market for a long time. Various brands, Inocom, and then they've moved on to so many, and now, but now, most recently, even vessel sealers and have come into the market, and they also have their own generators. And I've used some of them. I think they are quite good. I think they will definitely become if not a major player, they will become an important player in the market segment in the time to come. And if you don't embrace the China staplers, and not to say, I mean, if you ignore them just because they are Chinese staplers now, then I think you are losing out on a big chunk of technology that is available and you're not using it. I think I agree with you on that. So yeah, but moving forward, do you think the SGLT drugs will take a more important role compared? That means, do you think people like you and me will have no work one day?
I think the medication part is I think we still have a lot of side effect from the medication, right? We know that.
Ah, correct,
So I
correct.
think it is a matter of time in the surgical medical science, right? In the medical science, it is innovations and then the discovery,
So I'm back.
R&D. Yeah.
Ah, hi, Mahir, great. So we're talking
I've done
about
ileostomy.
We're talking about Chinese staplers.
Sorry, repeat again.
We are talking about Chinese staplers
Yeah,
and
yeah.
Chinese energy devices. We are saying that will it come at, I mean, like how BYD is dominating the EV market now. We find that there are still many surgeons who are doing bariatric or surgical oncology and saying, I don't use Chinese staplers. And they feel very proud that they say that I don't use Chinese staplers. But actually, if you say that now and someone listens to you, they might be asking why. They're not so
Yeah.
bad.
Listen,
So,
listen. I also try to use known famous trademarks, but there are some Chinese companies. They are not as bad as 10 years ago. So
yeah,
every year the quality of staplers are getting better. So the market, they are actually surpassing the market. They are pushing the market with the price, with the economy of the countries like Turkey, Malaysia, and other countries, India, and many European, Romania, Polonia, and many European countries. We look for the better price for the good quality staplers because I mean patient doesn't want to pay more. But that doesn't mean that patient should actually have bad quality
yeah.
staplers and face with the complication. So if you are sure about the quality testing and everything for the staplers, it doesn't matter which country they are coming from. But I mainly stick on the staplers which are in the surgical field for more than 50 years. I mean, if you look at the Johnson and Johnson and Medtronic, I'm sorry to give their name, but they are used doing this
Yeah.
stapling technology for a long time. So Chinese one are getting closing the gap between those two, and I definitely have to say that they are not market leader at the moment, but they will be in the near future
I
quickly.
think most of us share with you the same sentiment, Mahir, that most of us have got this first wife, second wife theory, J and
Yeah,
J and Medtronic, and then we
yeah,
interchange here and there. Then it's very hard for us to take number three and number four.
yeah.
So
True.
so this I think is the but I think like what you said, they are getting closer and they are bridging the gap in technology very fast.
Definitely. I have been in
So
China, I mean, last year, and I visited one of the, I can give the name, Mikome factories and all the production processing period of the stapling for the surgery. And I have to say that I'm using Mikome as well. I have to say that they have a very good quality as well. So similar quality that actually you can get from some Chinese companies as well. And I believe in Europe, Panther is also very strong.
Mm. I think Ong is a strong believer in this. Ong, how do you think AI will kick in into bariatrics actually? Do you think
Yeah, I mean, I
where
have done robotic one today, and and then the rectum cancer. So AI in robotic surgery at the moment is just the stapling. So only AI that you can use during robotic surgery is the stapling technology. But I mean, the computer vision and data processing and everything is actually requires AI. So new robot, Da Vinci 5, and the other robot, there are something like 40 new robots coming. So most of them are not actually latest technology. But you will see that increased number of the robot will decrease the cost, and then we will have Da Vinci 5, for example, the new one, which you can actually have the haptic sensation as well during not only the AI. And also there are many new software programs that you can actually use with the robot to assess your data and also to use it for the teaching, and also with the haptic sensation and the control of robot by, I mean, automation in somehow in the robot might result in better quality surgery for the patient. But at the moment, most of the robots are slave.
Yeah, I also think most of it is sleeve. Yeah, that's the issue.
Slave, I mean, most of them are
Yeah. What
slave
about you,
robots.
Ong?
So
You think beyond the surgery, you think any other AI application that we can?
I think it's AI will, you look at the way currently, right? I mean, there's a DeepSeek, right? If you use the DeepSeek, you can see that the prompt and then the reasonable AI, right? These will come. So it is a matter of time, right? So for us
Yeah.
as we be in the cancer as a surgeon or cancer surgery, right? So one is a Professor Myers about the robotic automation in the future, right? That is, we call it digital surgery. That is coming on the way, right? And then the other one is the big data analytics, right? So we have
Yeah.
so much of the patient profiling, right? Patient genomics, patient microbiomes, right? All these data are available. And then now is the mitigation effect. Yeah. So all these will come together, and then you will have a big data analysis, right? Then which patients might be having which type of the medical treatment, right? For the bariatric
let me
and
let me
conditions. And then which will
let me
benefit from the heart surgery. Yeah. So this right is a matter of time. I think depends on how we build the algorithms and then how we analyze it. Yeah.
I have to
Yeah.
add. Let me add something to what you said about the big data. Actually, beginning of the time till 2012, whole data was actually 5 exabytes. So starting every 2 days, we are having 5 exabyte data. So it's huge data. So we definitely need artificial intelligence. We definitely need big data analysis. We definitely need computer vision because one laparoscopic surgery's videotape, 1 hour videotape, is actually equal to something like 65 CT scans. I mean, a lot of data is there. So in order to analyze all that data, we need computer vision, we need natural language processing, we need big data for the artificial intelligence. Future, that will make life easier for surgeon, for everyone, for engineers, for everyone. But we should start using robot and dealing with the artificial intelligence, processing our data by using that kind of algorithms will make life easier. We should start. I mean, some of my friends say that it's too late for them to learn artificial intelligence, robotic surgery,
I
digital
don't think
surgery,
so.
virtual reality. But I mean, it's not too late. You have to start
Yeah. Yeah.
sometime in order to catch the train. Otherwise, you will lose everything.
Great. Maya, I think we are coming to the end of our segment. Okay, do you have what is your vision for ELSA Mahir as the president? And what is your hope for ELSA as a society?
Mhm.
And what is what do you see it to be in years to come?
Thank you. The main trouble with the general societies like ELSA, like EAS, like SAGES, the main trouble is there are a lot of subdivisions, I mean, there are societies for everything, every organs, even esophagus and stomach is different. Hepatobiliary is different. There is a society for pancreas only. There is a society for colorectal, but now there's going to be societies for rectum only. So there are robotic societies, and there are some, a couple of robotic societies as well. I believe they should be in minimally invasive societies. Robotic surgery society shouldn't be different. It should be in part of ELSA. So either for the ELSA, as we discussed with the executive board and as well, either we need to increase the attention of the people to join our society. I believe ELSA is doing great well with this one. In order to do that, you should use social media, YouTube, Instagram, Facebook. Facebook is too old now for the young people. You should be on Instagram and YouTube channels as well. So ELSA is doing that as well. So most of the societies are actually behind ELSA. So the second thing is we have IFSES president. So at the moment, David Lomanto is the IFSES president. So he's actually managing all endoscopic societies in the world. So he's the chair and the president of whole societies, including something like 40 societies together. So we should use for ELSA, and we should increase the outreach program number, teaching for the young people. And also we should do some on-site surgeries. You know, I mean, I can do online. I was doing robotic rectum, so I should actually do, or I was doing robotic mini gastric bypass. I should actually join ELSA for the live surgery, just showing my surgery and sharing the data with the people. So that will increase the attention, the attraction of the young people as well. So we need to increase the number of the members as well from every countries. So as far as I believe, Malaysia is doing good, and Turkey is increasing, and Japan, China. So all countries, and we have newcomers, you know, like Jordan just joined ELSA, and we have Azerbaijan, Uzbekistan, Kyrgyzstan is coming. Russia is actually interested to join ELSA as well. So we need to discuss this during the board meeting as well. So, but we should know that for the future, general societies will decrease the number, and especially companies are actually supporting mainly for the subspecialties rather than general surgery or general endoscopic laparoscopic societies. Difficult to find a sponsor, you know, for the congresses.
Yeah.
Thank you for having
yeah,
me. Yeah, thank you for
my
having
pleasure,
me
Mahir. I think we
for
want
the
to also
seventh
stress
episode.
that we
Yeah,
are having a discount for ELSA membership and
yeah,
we've extended it until the
yeah,
end of March. And we encourage anyone who listens and who are not members yet to please join in on to ELSA during this time.
yeah.
Just click the link and you get a discount, and it's good time to join. Thank you guys,
I
and
think in
Thank
the
you.
Kafu, we
Thank
need
you.
to announce about the World Congress of Endoscopic Surgery.
please
Yeah,
carry on. Yeah.
Yeah, so thanks, Professor Mahir, for the time, and then Kafu for co-chairing. So I think that on behalf of the Singapore team, I would like to invite all of you to join us in the World Congress of Endoscopic Surgery. Congress chairman is Professor David Lomando, who is the IFSES president. So it will be from the November 4 to 8. It will be the very nice scientific program as well as a pre-congress workshop. Please submit your abstracts. There will be travel grants available as well. So please look
perfect.
out for the wces.com and then the join us in Singapore. Thank you very much. Thank you all.
Thank you, guys. Thank you
Bye.
very much.
Bye.
That was great, and hope to see you shortly. Thank you, David.
Bye. Bye.
Bye-bye.